Hey everyone, and welcome to a deep dive on acute pancreatitis.
Yeah, we're going deep today using the latest guidelines from the American College of Gastroenterology.
We're talking cutting through all the noise and giving
Really?
you the info you actually need,
Exactly. Consider this your masterclass on acute pancreatitis.
tailored just for you.
That's right.
So picture this. You're suddenly hit with this super intense pain right in your abdomen.
Oh, yeah.
You're thinking, oh man, bad burrito or something.
Right.
But the pain, it just won't quit. That, my friend, could very well be acute pancreatitis, which basically means your pancreas is inflamed.
And it's way more common than people realize.
Really.
Yeah, and here's the thing about acute pancreatitis. It can be really different from one person to the next. Like for one person, it might be pretty mild, a minor annoyance really, but for someone else, it can be incredibly severe.
Wow. So unpredictable.
Yeah, and that's why getting on top of it quickly with the right management is so, so important.
It's like every case has its own personality or something.
You could say that.
Uh,
And it's a big deal, just to give you an idea. The U.S. spends over $2.5 billion on acute pancreatitis every year.
wow, that's a lot of money.
It is. And while thankfully most cases are mild, almost 20% of patients develop complications that need serious intervention.
So you could be one of the unlucky ones.
Potentially.
So with all this talk about acute pancreatitis,
Hmm.
how can we even be sure that's what's going on? How do doctors diagnose it?
Well, there are three main things we look at. It's like a three-legged stool. First, that abdominal pain we were talking about. Usually it's pretty distinct.
Okay, so pain is the first leg of the stool. What about the other two?
The second thing we look for is elevated levels of certain enzymes in your blood, specifically amylase and lipase.
Enzymes, huh? What do those have to do with the pancreas?
The pancreas produces these enzymes to help with digestion, so when it's inflamed, it releases more of them into the bloodstream.
Ah, I see. So by checking the levels of these enzymes, doctors can get an idea of what's going on.
Exactly. Lipase is actually more reliable than amylase for diagnosing acute pancreatitis.
Lipase. Got it. So that's two legs of the stool, pain and enzymes. What's the third?
Imaging. We need to actually see what's happening in there. So doctors will use things like ultrasounds, CT scans, or sometimes even MRIs.
That makes sense. Get a visual confirmation.
Exactly. It helps us confirm the diagnosis and rule out any other potential issues.
Okay, so we've got pain, elevated enzymes, and imaging, all pointing towards acute pancreatitis. But what causes this to happen in the first place? What throws the pancreas out of whack?
Well, there are a couple of major culprits that we see time and time again. The most common by far is gallstones. They're responsible for about 40 to 70% of cases.
Gallstones. Wow, I had no idea they were so closely linked to pancreatitis.
Oh, yeah, they are. And then, of course, there's alcohol, which is involved in something like 25 to 35% of acute pancreatitis cases.
So those are the heavy hitters, gallstones and alcohol. What about other things that can trigger it?
Well, high triglycerides can definitely be a factor, especially if the levels are really high. We're talking over 1,000 milligrams per deciliter.
High triglycerides, that's another one I wouldn't have necessarily connected to pancreatitis.
It's important to remember. And it's serious enough that doctors will want to keep an eye on your triglyceride levels even after you're discharged from the hospital. They'll probably check them again in about a month.
Wow, they're not taking any chances.
Better safe than sorry. And then there are some less common causes, things like certain medications, infections, and even in some cases, tumors.
Okay, so a pretty wide range of possibilities.
It is. But the key thing to remember with all of this is that identifying and treating the root cause is absolutely crucial.
Because if you don't figure out what's causing it, the problem's just going to keep coming back,
You
right?
got it. It's like putting a Band-Aid on a much bigger wound. You need to address the underlying issue to truly solve the problem.
Makes total sense.
Hmm.
Now, I've heard of something called idiopathic pancreatitis. What is that exactly?
Ah, yes, idiopathic pancreatitis. That's when someone has repeated episodes of acute pancreatitis, but we can't pinpoint a specific cause.
So it's a bit of a medical mystery.
In a way, it is. We do know that even if we don't see obvious gallstones in these patients, sometimes doctors might recommend removing the gallbladder anyway.
Really? No gallstones, but they still take out the gallbladder. That seems counterintuitive.
It might sound strange, but research has shown that this can significantly reduce the risk of future attacks in people with this type of pancreatitis, even if those gallstones aren't causing obvious problems.
That is fascinating. So we've established that acute pancreatitis can be caused by a whole bunch of different things. But how do doctors figure out how serious each case is once it's been diagnosed?
That's where assessing the severity comes in. It's
Yeah.
kind of like figuring out how strong an earthquake is.
An earthquake.
Yeah, we need to know if we're dealing with a minor tremor or a major catastrophe, and the same goes for acute pancreatitis. The severity is a huge factor in determining the best course of action.
Okay, the earthquake analogy. I like that. You got to know how bad the damage is. So how do doctors go about figuring out where someone falls on the acute pancreatitis earthquake scale?
Well, we break it down into three main categories: mild, moderately severe, and severe.
Okay, so mild. That sounds pretty self-explanatory.
It is. Mild acute pancreatitis is like a little tremor. It's usually uncomplicated and clears up fairly quickly.
Not too bad. And then there's moderately severe. What pushes it into that category?
With moderately severe acute pancreatitis, we start to see some temporary problems with organ function, like the kidneys or lungs might be working less efficiently for a bit, or there might be some local complications. Think of it like a moderate earthquake. Definitely noticeable some damage, but nothing we can't handle.
Okay, so far so good, relatively speaking.
hmm
But then we have severe acute pancreatitis. What makes it so, well, severe?
Severe acute pancreatitis is the real deal. This is where we see persistent organ failure. And unfortunately, in some cases, it can even be fatal.
That escalated quickly. What causes it to become so dangerous?
One of the main culprits is something called pancreatic necrosis, which means that parts of the pancreas actually start to die off. It's like the aftershocks of that earthquake, causing more and more damage. And generally speaking, the more necrosis there is, the more severe the pancreatitis is going to be.
So that's the real danger zone when parts of the pancreas start dying. It's like you said, a house fire. You got to put it out before it spreads and takes out the whole block.
Exactly. And that's why doctors are always on the lookout for signs of trouble, even if someone comes into the ER seemingly stable. Severe complications can develop really quickly when you least expect it.
So how can doctors tell if things are about to go south? Is there some kind of early warning system they use?
I wish it were that simple. Unfortunately, even with all the advances in medical technology, predicting the severity of acute pancreatitis early on is still a huge challenge. It's kind of like trying to predict an earthquake. We can look for indicators, but there's no foolproof method.
So no crystal ball then.
Yeah.
But there have to be some clues, right?
Yeah.
What are some red flags that doctors look out for?
We look at things like lab values. For example, elevated hematocrit high BUN, which stands for blood urea nitrogen, and increased C-reactive protein can all be potential indicators.
So those are some things to watch out for. But I'm guessing it's not as simple as just looking at one value and making a call, right?
You're absolutely right. It's not about any single test in isolation. It's about putting all the pieces together, like a puzzle. We use those lab values in conjunction with the patient's symptoms, their medical history, the whole picture, to get a clear understanding of what's going on.
So it really is like detective work, looking for those subtle clues to solve the case.
Precisely. And that's where the art of medicine comes in. It's about careful monitoring, a personalized approach, and open communication between the patient and their doctor. Don't panic over a single test result. It's all about the bigger picture.
That's reassuring to hear. So once acute pancreatitis is diagnosed, whether it's mild, severe, or somewhere in between, what happens next? What are the first steps in getting this thing under control?
The absolute cornerstone of early management for acute pancreatitis is aggressive intravenous hydration. And I'm not talking about sipping on some water here. We're talking about getting those fluids into your system as quickly and effectively as possible.
Okay, IV fluids, got it.
Yeah.
But is it just your regular saline solution they use, or is it something more specialized?
We often use a solution called lactated ringers, and there are a couple of reasons why it's often preferred. First, it does a better job of maintaining the right balance of electrolytes in your body. And second, some research suggests that it might be a little better for pain management compared to normal saline.
Pain management is a huge deal with acute pancreatitis. So anything that helps with that is a definite plus. But back to hydration. How aggressive are we talking here? Are we talking about hooking someone up to an IV drip and pumping them full of fluids and they're like a water balloon?
Not quite. We aim for what we call moderately aggressive hydration. It's all about finding that sweet spot. We want to make sure we're adequately replenishing fluids, but we also don't want to overload the system. It's a balancing act.
So it's about finding that Goldilocks zone of hydration. Not too much, not too little, just right. But how do doctors determine the right amount of fluids for each individual patient?
That's where those lab tests we talked about come in handy again. By keeping a close eye on hematocrit and BUN levels, doctors can fine-tune the fluid strategy and make adjustments as needed.
It's all about that personalized approach, constantly adapting and adjusting based on how the patient is responding. It's like a medical dance.
You could say that. Now, you might have heard of a procedure called ERCP, which stands for endoscopic retrograde cholangiopancreatography.
Wow, that's a mouthful.
It is. But the important thing to remember about ERCP is that it's not a routine procedure for every case of acute
So it's
pancreatitis.
not part of the standard protocol.
Right. It's more like a specialized tool in our arsenal that we use in specific situations. For example, if someone has an infection in their bile duct, a condition called cholangitis, that's when ERCP might be necessary.
Okay, so ERCP, definitely not a routine procedure, but good to have in our back pocket if needed. So let's switch gears for a second, talk about something that I think causes a lot of confusion when it comes to acute pancreatitis antibiotics.
Ah, yes, antibiotics. The age-old question to use or not to use.
Exactly. For a long time, the thinking was that we should give preventative antibiotics to anyone with severe acute pancreatitis just to be safe, even if there wasn't a confirmed infection.
The old better safe than sorry approach.
Exactly. But here's where things get interesting. Recent research has shown that this might not be the best approach after all, at least not for everyone. Wait, so we might have been giving people antibiotics unnecessarily.
It happens. Early studies showed some promising results with this approach, but larger, more recent trials haven't been able to replicate those findings.
Ah, science always keeping us on our toes. So when are antibiotics actually necessary in the treatment of acute pancreatitis?
Antibiotics are absolutely essential when we're dealing with infected necrosis, which is when there's a confirmed infection in the dead pancreatic tissue. In these cases, antibiotics are crucial for fighting off that infection, and they're often used in conjunction with surgical intervention to remove the dead tissue.
Got it. So antibiotics, definitely a lifesaver when they're needed, but not a one-size-fits-all preventative measure.
Speaking of things that are essential, let's talk about nutrition. I know this is an area where the thinking has really evolved in recent years.
It really has. For a long time, the go-to approach was to keep patients on a strict NPO order, which means nothing by mouth for an extended period.
The old starve the beast method. Exactly. But here's the thing. Emerging research is suggesting that this approach might actually do more harm than good. We're seeing a shift now towards early oral feeding, even within the first 24 to 48 hours, for mild cases of acute pancreatitis.
Wow, that's a pretty big change. What's the thinking behind that shift? Why the change of heart?
It all comes down to supporting gut health. It turns out that early feeding, even if it's just a little bit, helps to maintain the integrity of the gut lining, which can actually help to prevent complications down the road.
So we're not just feeding the patient, we're nourishing the gut itself.
Precisely. And here's another surprise. We often start patients on a low-fat solid food diet right away.
Hold on, solid food. I thought it was all about easing back in with clear liquids and the like.
That was the old school of thought. But studies have shown that starting with a low-fat solid diet is not only safe, but it's often preferable to the traditional clear liquid progression. It might seem counterintuitive, but it actually seems to help with recovery.
So we're ditching the baby food and going straight for the good stuff.
In a way, yes. Now, for patients with more severe cases of acute pancreatitis, we often opt for enteral nutrition, which basically means delivering nutrition directly into the stomach or small intestine via a feeding tube.
That makes sense. But what about the old standby IV nutrition TPN?
We try to avoid TPN whenever possible because it carries a higher risk of infection. Enteral nutrition, when feasible, is generally the preferred route for most patients.
Got it. Enteral feeding first, TPN, only if absolutely necessary. Makes sense. Now let's talk about something that I think a lot of people get anxious about when it comes to acute pancreatitis surgery. When is surgery actually considered a necessary part of the management plan? Okay, surgery, I get it. It's a big deal for a lot of people. So when does it actually become a necessary part of the acute pancreatitis game plan?
Well, let's start with gallstone pancreatitis. If someone has mild gallstone pancreatitis, doctors are now recommending a cholecystectomy during the same hospital stay.
So they go ahead and remove the gallbladder to prevent future episodes of pancreatitis.
Exactly. It's kind of like removing a ticking time bomb. Plus, the procedure is very safe and effective these days, and it significantly reduces the chances of having those painful pancreatitis flare-ups down the road.
That's good to know. But what about those more complicated cases where there's necrosis? We talked about how serious that can be.
Right. Necrosis is a whole other ballgame. In those situations, surgery is generally reserved for infected necrosis, or if the sterile necrosis is causing a lot of symptoms and isn't responding to other treatments.
So it's a judgment call based on the individual patient and how they're doing.
Precisely. And even when surgery is necessary, we often wait several weeks after the initial pancreatitis episode.
Why wait? Wouldn't you want to get that dead tissue out as soon as possible?
It's actually better to give the tissue some time to organize before we go in there. Think of it like letting a wound scab over before you try to clean it. Waiting allows for better surgical precision, reduces the risk of complications, and improves the chances of a successful outcome.
So patience really is a virtue, even in surgery.
Absolutely. And here's another piece of good news. We're moving towards using minimally invasive techniques whenever possible. Laparoscopic surgery for necrosis is becoming increasingly common, and it comes with a lot of benefits for the patient: less pain, faster recovery, and potentially fewer complications.
So it's like the surgical world is finally catching up with our desire for quicker healing and less invasive procedures.
Exactly. It's a win-win situation for everyone involved.
Well, we've covered a lot of ground today, from the initial symptoms of acute pancreatitis all the way to the role of surgery and the latest research on management.
Mhm.
Before we wrap up, is there any final advice you would give to someone who's navigating their own acute pancreatitis journey?
I'd say the most important thing is to be your own advocate. The more you understand about this condition, the better equipped you'll be to ask the right questions and make informed decisions about your care. Remember, you're not alone in this. There are resources available to support you, and your healthcare team is there to guide you every step of the way.
I love that knowledge is power. And to our listeners, we hope this deep dive has given you the information you need to face acute pancreatitis head on. Until next time, stay curious, stay informed, and take care.